We would like to thank Amgen for providing an unrestricted grant to support the IACH webinar series.
Hi, everyone. It's my honor to be here with you for the IACH virtual series. I'm Dr. Naveen Pemmaraju, Associate Professor of Leukemia and the Director for the Program of BPDCN at MD Anderson in Houston, Texas in the USA. I want to especially thank Dr. Mohammed Modi and the IACH team for this special invitation. And I'd like to spend our time together talking about novel therapeutic approaches in the rare disease BPDCN targeting CD123 and beyond. I am an active clinical trialist, and these are my COI disclosures. We will be indeed talking about off-label, off-protocol approaches. Blastic plasmacytoid dendritic cell neoplasm, or BPDCN, is an aggressive hematologic malignancy with poor overall survivals and a quite aggressive clinical course. This disease is different from many of our blood and bone marrow cancers in that the predominant manifestation is the skin in almost all patients. This is followed by bone marrow, blood, lymph node, CNS, and other extramedullary sites. And so it represents sort of a hybrid between AML, ALL, and lymphomas. Well, there's no recurrent sine qua non cytogenetic pathognomonic feature, but there is an IHC flow marker, CD123, or IL-3 receptor alpha, which has become the hallmark of this disease. In addition, positivity for CD4 and 56, or think 1, 2, 3, 4, 5, 6, has given us a framework and a triad of sensitive markers for this disease that's really changed names over so many decades. In addition, modern new markers have added almost 100% specificity, including TCL1, CD303, and TCF4, which allow us to differentiate the rare BPDCN from maybe the more common AML with leukemia cutis, cutaneous T-cell lymphoma, etc. Well, the big breakthrough in our field based on the CD123 finding was the development and subsequent approval of tagraxofusp, SO401, which is the first, and as of this recording, only US FDA and EMA approved CD123 targeted agent. So let's dive deeper into BPDCN, shall we? This disease has had every single known therapy thought of. Initially, historically, when it was thought to be more of a skin-based disease, localized therapies such as skin-based therapies, including even topical agents, radiation, and other systemic therapies aimed at the skin were attempted. Then, of course, the name changed over time, 2008 into 2016, where BPDCN is now recognized as its own hematologic malignancy. Multi-agent systemic chemo regimens have been employed, most commonly borrowing from acute lymphoblastic leukemia, ALL, AML, lymphoma, and even multiple myeloma-based regimens, with the basic principle being multi-agent chemotherapy, allogeneic stem cell transplant in the first remission, and some form of CNS prophylaxis if it's available. Now, most of the patients, though, with BPDCN, unfortunately, right, are older, unfit comorbidities, and so many of these approaches don't even apply. And so there you're using reduced intensity chemo, hypomethylating agent, and of course, now with the breakthrough in CD123 and subsequent investigation of venetoclax and BCL2, we believe there might be some more options for patients with BPDCN in the real-world clinical experience. All right, so let's start to look at this evolution of therapy. Historically, we're talking about an overall survival of 1 to 1.5 years, despite multi-agent chemotherapy. On the left is a selection of some larger retrospective series in Europe, mainly focusing on two facts: that whatever regimen is used, primarily AML-based regimens, a CR rate of about 50% with a pretty high early death rate in induction, including 17, 26% sepsis, infections, hospitalization. So pretty suboptimal outcomes with chemotherapy alone. In our own experience, chemotherapy, primarily an ALL-based approach using the Cantargia hyper-CVAD paradigm, we have slightly higher rates in terms of outcomes with OS and CR1, but still really long-term outcomes are dismal. And whether you have skin versus marrow disease, these patients oftentimes will have an aggressive course. And so again, urgent new therapies were needed. The question of stem cell transplant and the role and timing of transplant is an important one. Just like many of our aggressive heme malignancies, allo transplant in CR1 appears to be beneficial for that young fit subset. There is some question of the autologous stem cell transplant that we have done in select few patients. The significance of that maneuver will need to be tested over time, particularly in maybe skin-limited patients or older, frail patients who cannot go for intensive therapy. This is Aoki and colleagues from Japan 6 years ago showing a benefit for both the auto and allo approaches. Well, so now we need to go back to the drawing board. Perhaps a more targeted therapy approach might be a benefit. The putative cell of origin in BPDCN is thought to be a PDC, or a malignant precursor of the PDC, plasmacytoid dendritic cell. This is an important cell in our blood and immune system. It's important in the toll-like receptor pathway, so innate immunity, the production of interferons, and then the liaison into the adaptive immune system. Therefore, marking the PDC as an important cell just in normal immune system functioning. So when we look at the PDC further, particularly the malignant PDC, there are several attractive markers, the CD123 surface target, which we'll discuss all about. There are other markers, including 56, CD303, CD4, et cetera, the internal markers of TCL1 and TCF4. So sort of personalized predator drone attack, if you will, very specific attack on these cells is hypothesized that could be of benefit to our patients. Well, a couple of breakthroughs in the field. So this is 21 years ago now that Jordan et al. Showed that indeed the IL-3 receptor alpha, or CD123, is a surface marker that's unique to human AML stem cells, that there's a differential gradient in between the malignant hematopoietic stem cell compartment and the normal one, and that this difference may be exploited as a therapeutic target for CD123 overexpressing heme malignancies. Well, taking a deeper dive into the IL-3 receptor alpha, CD123, has been fascinating. It's a transmembrane alpha chain of the IL-3 receptor. In addition to being overexpressed in PDCs, it's also expressed on the surface of basophils, monocytes, eosinophils, and a host of other different blood cells. And therefore, because of this, in addition to BPDCN, you're going to see an overexpression of this 123 in various myeloid and lymphoid malignancies, including but not limited to AML and MDS, hairy cell leukemia, lymphomas, lymphoid leukemias, etc. A parallel story to this was that of diphtheria toxin. Now, this is a story that dates back 50-some years in the anti-neoplastic therapy realm. This is work done in the 70s by Thorpe and Ross group, which showed that the diphtheria toxin is in fact toxic to lymphoblastoid cells, either by itself or in combination with chemoimmunotherapy agents. And so the scene is set. Our colleague, Dr. Art Frankel, was the first to put together these two concepts, combining a truncated diphtheria toxin payload with human recombinant IL-3, and therefore creating this targeted therapy later known as SL401 or tagraxofusp. Now, specific in vitro and in vivo data for BPDCN nicely shows that the tagraxofusp agent is in fact potent against BPDCN by itself, not extrapolating from AML or other tumors, so having its own primary data for the first time. We were then able to set out to conduct and conclude a phase 1 pilot study, which included a total of 11 patients, 9 of whom were available for a valuable response, showing the majority responded, 78%, with 5 CRs, and this work was published with our group in Blood in 2014, now 7 years ago. So that was a big paradigm shift in our field. We were then able to set out with the STEMline team to do the first multi-center, prospective, multi-cycle SL401 tagraxofusp study specifically for patients with BPDCN, both frontline and relapse refractory, and that trial schema is shown here. We first were able to do a stage 1 or lead-in, so that's a classic 3+3 design. Doses of 7 microgram, 9, 12 microgram were used. There was no formal MTD, but 12 micrograms was selected by the investigators to move forward in the stage 2 based on early toxicity and early efficacy signals. The stage 2 was then completed as an expansion, again, including both frontline and relapse refractory at the target dose of 12 microgram per kilogram IV, days 1 through 5 of a 21 to 28 day cycle. And then the stage 3 was then conducted as sort of a trial within the trial, pivotal confirmatory data set now focusing specifically on frontline patients and specifically on CR rate. Select inclusion and exclusion criteria shown below. Very important in this trial in that you have this diphtheria toxin conjugated IL-3 agent with a signal early on in the pilot study of a vascular or capillary leak syndrome. And so I want you to pay attention to the albumin, which was initially 3.0, then raised to 3.2 by investigator consensus, as this appeared to be the most sort of predictive factor for the development of the capillary leak syndrome. All right, so the trial was conducted in this fashion over several years, stages 1, 2, 3, shown here, median age indeed reflecting a real world population at 70 years with an upwards range of 84, mostly male. That's common in BPDCN, where most series have found it to be 3 or 5 to 1 random distribution of male to female. And interestingly, most of the patients who came to the study were frontline, not relapse refractory. And the baseline sites of disease were as we expected, with the majority of patients having cutaneous involvement followed by bone marrow and other sites. And the vast majority of patients ended up receiving the target dose of 12 microgram per kilogram per day. Now, before I show you safety and efficacy, I have to emphasize in a rare disease field, any rare disease field, we had to come up with a set of response criteria. And I'm pretty proud of what we were able to put together as a group, as shown here. For the skin, we wanted to explain the subjective and objective, and so we borrowed from the successful MSWAT criteria in cutaneous T-cell lymphomas, so Olson 2011 as the reference. We used Cheson criteria for bone marrow and lymphoma for bone marrow and lymphoid staging, so PET-CT scan imaging. There was also the designation of CRC because serial skin biopsies were called on during the trial to explain that you had no detectable disease, but that there was some unclear residual microscopic skin disease. And so we were able to include that. All right, so safety of the drug. The most important signal for sure was that of the capillary leak syndrome predicted by the biology and early pilot study. We saw the CLS importantly at all grades, including deaths, 2 deaths in the early phase of the trial, which led to modifications, mitigation measures, which were easily implemented and followed thereafter. The key to the capillary leak syndrome, 3 lessons learned. 1, it usually occurs in the first cycle. 2, usually can be tracked by the baseline albumin and then the rate of kinetic drop of the albumin. And 3, with some simple measures following daily weights, fluid status, creatinine, LFTs, that this could be quite easily watched, educated about, and mitigated. Turns out that the capillary leak syndrome is not unique to the SL401 agent. A quick sampling of recently approved bacterial toxin-based drugs, the capillary leak syndrome has been seen in the Denlucan Diphthetox at a significant rate, and even a small signal in the Pseudomonas toxin-based moxetumomab, just to give an example recently of CLS, of course, a phenomenon that's been known for quite some time, Clarkson's disease, either by the disease state itself or cytotoxic or targeted therapies. And so in the modern paradigm, we must all watch out for the capillary leak syndrome, thinking about the albumin levels, as I mentioned, repleting the albumin as indicated, watching the body weight, fluid status very carefully during days of dosing and thereafter, holding the drug as per the label, which is how we did on the study. And then, of course, treatment, which may include maneuvers such as steroids, increased diuresis, vasopressors, ICU, and the fact that these patients can be salvaged out of the ICU even after experiencing this capillary leak syndrome. So BPDCN is a visual disease, including the skin in many patients, and this was one of my patients on the trial who had a phenomenal response after 6 cycles of therapy, keeping in mind that a lot of these patients with CD123 and other targeted therapy will experience resolution of the skin lesions even as early as 1 cycle. And so the concept here is that you have a drug that can decrease the skin lesions, bone marrow, and lymph nodes, resulting in a high rate of CRs. And so the Diphtheria Toxin IL-3 SL401 tagraxofusp drug was established. We were able to publish these results exactly 2 years ago in the New England Journal of Medicine. And this pivotal trial did lead to US FDA approval December 2018 on the basis of overall response rate of 90%, 90 in the frontline setting, with a 72% CR and 67% ORR in the relapse refractory setting. And then also recently has gained EMA approval just this past year in frontline adults only. I think the key in the US FDA approval is that it's ages 2 and older on the basis of a compassionate use series in pediatric patients. And then just to note, in the EU EMA approval, this is in first-line adult patients only. And so the summary from the tagraxofusp experience, lessons learned from pioneering a drug in a rare disease. We took a disease that was ultra rare, poor outcomes, no standard of care. We do now have the first targeted therapy. We have a new class of drugs, CD123, high response rates, majority of which were CRs, 45% of whom in the frontline setting were able to go to a stem cell transplant at median age around 70. We talked about the capillary leak syndrome, which appropriately has a US FDA black box warning. And then in terms of further investigation of the CD123 targeted agent, we are now moving and have active trials in AML, myelofibrosis, CMML, multiple myeloma, and several other areas. And so with the establishment of the tagraxofusp agent and experience, there was quite a bit of press that came out. After all, this is the first and only CD123 targeted agent, and I think it shed a nice light on this emerging area. The long-term follow-up includes looking at patients who were able to go to a stem cell transplant with TAG, and we were able to present these results earlier this year at the TCT tandem meetings. And basically, again, just showing that patients were able to be bridged successfully to a stem cell transplant and were able to show a significantly good median duration of response with minimal toxicity in the long-term setting. We'll, of course, continue to follow these patients even longer term. Again, several patients were able to go to auto transplants, and the question again is who is the right patient to go for this modality. Okay, so how else can we target CD123? Well, there's lots of different active areas. There's the antibody drug conjugate field with the lead molecule IMGN632. Of course, there's CAR T cell therapies, bispecific approaches in BPDCN, AML, and in CD123 expressing tumors. And a lot of these are in the early stages of clinical trial development. One advancing program outside of the tagraxofusp is the IMGN632. This is a new CD123 targeted antibody drug conjugate. I was able to present publicly the first results available for relapsed refractory patients with BPDCN at the IACH 2020 meeting. I'd like to give you a sample of those data. So IMGN632, ADC, high affinity binding to CD123, unique epitope, so a different drug than the SL401, has its own payload, an IgN DNA alkylating active agent. This agent has been tested in monotherapy and now has moved into doublet and triplet in AML, showing response efficacy in that setting. So looking at the IMGN 632 agent in particular in BPDCN was nicely analyzed by our colleagues in a PDX model, specifically from a patient with relapsed refractory BPDCN, showing really exquisite activity in this in vitro and in vivo model system for BPDCN specifically. So we went to the clinic, 29 patients treated in the relapsed refractory setting, median age of 72, upwards range of 82. So again, meeting a real world population, majority of patients male, majority of patients having skin involvement followed by bone marrow and lymph node. Interestingly, BPDCN commonly presents with a prior or concurrent malignancy. So a fourth to a quarter of a patients had this phenomenon. So that's common in our field. And then you can see the rest of the characteristics here. I think most importantly, 45% had prior exposure to tagraxofusp. So favorable safety profile, this drug is given IV Q3 weeks, can be given in the outpatient setting. No capillary leak syndrome seen in this first look in the data set, no drug-related discontinuations, and no drug-related deaths with a 30-day mortality of 0. Most common AEs are shown here: thrombocytopenia, febrile neutropenia, hyperglycemia, and 10% each. And there were a couple of patients, as noted on this slide, with liver-related AEs. Now, in terms of efficacy for IMGN 632 in this relapsed refractory cohort of BPDCN, 29 patients, intention to treat, the overall response rate was 29% in this heavily pretreated group, including 2 CRs, 2 CRCs, 1 CRI, and 3 PRs. Importantly, patients with prior TAG exposure also had benefit with an ORR of 31% in these patients. Time on treatment and response details are shown here. At the time of the data cutoff, 39% of patients remained on treatment. And as has been seen in other BPDCN therapies, responses in the clinic were quite astonishing, rapid in some cases with disappearance of skin lesions, reduction of bone marrow blasts and lymph nodes quite quickly. And durable responses have been seen in the early going with this agent. From a visual standpoint, this is one representative patient, a 69-year-old woman with both MDS and BPDCN, who had partial response to one cycle of tagraxofus, then had chemotherapy and was enrolled on this program, having significant clinical benefit with resolution of lesions in multiple areas. And so the conclusion from the IMGN 632 experience has been that this is a large prospective group of uniformly treated and followed patients with BPDCN with a single therapy, monotherapy, personalized targeted therapy approach, favorable safety profile, as I showed you, 29% overall response rate, and that's actually 31% in prior TAG treated patients. And this data set did receive FDA breakthrough therapy designation for relapsed refractory BPDCN, and the trial now is moving into the frontline setting. And so those are the two lead CD123 agents in our BPDCN field. Now turning to beyond CD123, there's a burgeoning field of research there. One of the lead candidates has been targeting BCL2 with the venetoclax agent, which has shown so much promising activity in both lymphoid and myeloid diseases. This was our work with the Dana-Farber Cancer Discovery, published 2017, really showing the first evidence for venetoclax, both in the lab and in the clinic, monotherapy activity. This then led to a number of different clinical trials in our two groups, including with Ven-HMA approach and Ven with chemotherapy. In a subsequent letter that we submitted to New England Journal, we were able to show in a quick series of 3 patients the benefit of hyper-CVAD plus venetoclax in patients in the real-world setting with BPDCN in both the relapsed and a frontline setting. And this has led to a formal clinical trial at our institution with all of these modalities, so hyper-CVAD, Ven, SL401 in alternating doublet therapy. In this schema for this trial, one of the key factors has been the incorporation of lumbar punctures as in an ALL paradigm, and I'll show you data later onto why that's important. But the supposition is that we still do not know if the CD123 active agents are crossing the blood-brain barrier or not. And so with this data set, I think one way to analyze this is that in the frontline setting, you have options now. So you have the tagraxofus, which is approved frontline relapsed refractory, all lines, ages 2 and older. Historically, chemotherapy in some of these series, variable, whether it's ALL versus AML, but clearly has activity in this somewhat chemosensitive disease. And then, of course, clinical trials such as the IMGN 632, now available in the frontline setting, and then combinations of these agents, which should be done on clinical trials. And then remember the curative modality of allogeneic stem cell transplant 01, and let's put a question mark on auto in select patients. In the relapsed refractory setting, of course, clinical trials should be the top consideration, and then combination therapies with 123, HMA, chemo, BCL2, et cetera. Let's also mention that there are several CAR T programs in development for BPDCN, and we have a post-transplant maintenance study with SL401 here at our center. So I want to spend the remainder of our time letting you know that we have several hot topic areas that are of interest to our patients and caregivers. I mentioned this, but this is becoming a huge area in our field, and I wanted to dedicate some time in this lecture to it, and that's the question of CNS involvement in BPDCN. So how frequent is it? This turns out to be a very important study from my colleague, Dr. Martine, which was done now 4 or 5 years ago, which suggested that when lumbar punctures are implemented systematically in BPDCN, which we did not historically do, that there was a higher than expected rate of CSF positive, either at the time of progression relapse or even just when screening in the frontline setting. And so the supposition here is that in the historical chemotherapy era, some sort of CNS prophylaxis must be considered for patients with BPDCN. And of course, the question was then maybe the targeted agents, CD123, would overcome this. Well, to our surprise, that has not yet happened. And so with Dr. Kantarjian and my colleagues here at MD Anderson, we just recently published in Blood 2 weeks ago, June of 2021, our analysis of our series at the MD Anderson, 103 patients, astonishingly high rate of CSF. I was quite surprised to see this, 22% positive at any time. Most of these patients were occult, asymptomatic, These are just in the LPs that we did, right? We weren't doing them systematically at any point in this disease, and a really quite high rate in the frontline setting on routine LPs. The supposition here is twofold. One is, can we identify which patients may have a higher rate of CSF positive? And you can see some of our p-values were significant for those with anemia at baseline, maybe a higher frequency of TET2 mutations and variants, and a higher rate of bone marrow involvement. Almost all the patients, 96%, who had CSF positive also had bone marrow disease. But I think really what I am getting out of this data set, and what I would call on all my collaborators around the world, is that this is a very high rate of CSF positivity. This includes the modern era, up until the present time. And I think that what it makes me realize is that I would like to call on everyone to implement systematic use of lumbar punctures with IT chemo, methotrexate Ara-C, for example, simply as we do in the ALL, Burkitt's, Philadelphia positive paradigm. So potentially even borrowing that paradigm into ours. And I think this is an important area of future investigation, debate, and discussion. All right, so moving on from this CNS topic, another topic is just diagnosis. This is a hard disease to diagnose. I make no bones about it that I have a dedicated heme path team, dermatopath team, transplant team, and we regularly meet to discuss these difficult cases. And I think the one that I'm seeing is the toughest is the differentiation between AML leukemia cutis and BPDCN. And I think some of these newer markers will help. TCF4 has been found to be a transcription factor that's important for maintenance and development of normal PDCs, and in fact is a master regulator of BPDCN transcription. In this beautiful paper by Cervelli and Stout from Cancer Cell in 2016, they went further to show that not only TCF4 can help us in diagnosis, but that there might be other agents outside of the ones that we're testing that could have potential for clinical benefit. And my colleague, Dr. Joe Khoury here at MD Anderson, heme pathologist expert, has incorporated and designed a TCF4/CD123 dual stain, which essentially has 100% specificity for diagnosis of BPDCN, and has been quintessentially helpful in our diagnosis of these patients. Well, other special issues in this area, anytime you have dedicated your life, as I have, to a rare disease, you've got to try to find patients and connect with people out there who need the information the most. And one way that's helped me really quite simply to connect with people out there all over the world has been that of social media, and in particular Twitter. We've done some research in this area and published a few papers showing that the establishment of a disease community, in this case hashtag BPDCN on Twitter, has allowed us to, from an organic, grassroots, non-sponsored way, just individual to individual, connecting with people out there who have questions about BPDCN. And I've been personally gratified to see the growth and use of this hashtag, and basically it means that there's more people out there than you think. Turns out that rare diseases are not as rare as we think, and if you have that rare disease, if you're that N of 1 out there, it doesn't matter if something's rare or common, it's affecting you, your brother, your sister, your parent, your loved one, and therefore that's what matters. We've got to keep going for breakthroughs in these rare diseases together. Several other issues that have come up that I'll leave you with is the question of CD123 expression itself. In fact, in 2021, there's still no standard way to assess CD123. It can be done by flow, by IHC, quantitative, qualitative, you name it. But there is a question of level, expression, density, and maybe even isoforms that could play a role in the expression of the 123, and possibly, maybe, the hypothesis is, could that matter for therapeutic responses? And my colleague, Dr. Sohail Menashi at Fred Hutch in Seattle, has been really leading this effort, just as their work was in the CD33, now looking at CD123 isoforms. So we await those data. In the pediatric setting, a very important area of investigation, there is a hypothesis that pediatric BPDCN, even more rare than our older counterpart, could be somewhat different of a disease in terms of its clinical course, presentation, maybe even pathobiology, so active investigation. I mentioned that the SL401 gained approval in ages 2 and older, largely based on the 3-patient series nicely analyzed by Dr. Anthony Stein and colleagues at City of Hope. And I think the supposition here is that you did have a significantly well-tolerated drug in a heavily relapsed refractory setting with some transient responses. So I think much more investigation is needed of CD123 targeted agents in pediatric BPDCN, and we will seek out mutational profiling and try to compare adults versus pediatric cohorts. Yet another active area is that of prior and concomitant hematologic malignancies I mentioned briefly earlier. It's pretty amazing to see that maybe 20 to 25% of patients with BPDCN will actually have a prior or concomitant hematologic malignancy. So that's not even including solid tumor cancers. And the most commonly by far in our series and others has been MDS-CMML. I was recently able to collaborate with Dr. Dan Wiseman, Dr. Justin Taylor, Dr. Mrinal Patnaik, and others, a nice case report analyzing sort of this story of divergent clonal evolution of BPDCN and CMML, really centering around the TET2, the shared TET2 mutated origin that's very common in both of these diseases. I think it's interesting. It raises the question about CHIP, MDS, CMML, BPDCN, immature versus mature PDC aggregates, which can be seen. It's a whole other area of active investigation. And finally, the last area to discuss is that of PDC AML. Boy, if this wasn't complicated enough. So we have BPDCN, which now we're finally understanding. We have AML. Could it be that there is a small overlap syndrome in between the two? You bet there is. I do believe there is. This is a recent paper in Blood from last year from Dr. Ross Levine and colleagues showing that maybe 3 to 5% of AMLs are this BPDCN-like or PDC AML. The concept here is that you have CD34 positive AML, but you also have markers and features of BPDCN with PDCs of 2% or more present in the bone marrow sample. I was fortunate to be invited to write the editorial on this, and so I really did a deep dive into this data, and I was astonished to see that 70% of these patients had a RUNX1 mutation, purportedly leading to an increased PDC transcriptional program. That's a fairly new finding for our field. These patients with PDC AML had more skin lesions than the regular AML. That's a new finding in the field, possibly worse OS. And that Dr. Levine's group went the extra step to show that CD123 targeting with TAG in their preclinical PDX models showed both elimination of PDCs as expected, but also a decreased leukemic burden. And so the suggestion, clinical hypothesis would be in this rare subset, PDC-AML, could CD123-based targeting approaches have clinical benefit? And so we'll be actively pursuing that in the coming years. So I think in conclusion, as you've seen the data here, as you think about the BPDCN and PDC fields, I asked the question, targeting the PDC, an elusive and difficult target, could it be as easy as targeting CD123? With that, I'd like to conclude by thanking my collaborators, both here at MD Anderson, including Dr. Marina Konopleva and Dr. Hagop Kantarjian, and my entire multidisciplinary team here, my external collaborators throughout the United States and the world, and certainly our partners in the nonprofit, advocacy, pharmaceutical, grant funding agencies, all of whom have come together to help us eliminate this rare disease of BPDCN. Thank you so much for your time, and happy to correspond with you for questions over the coming weeks.